I'm going to introduce the first speaker. It's Torben Jørgensen. He's going to talk about the birth of the Glostrup population studies. And he was actually also a leader of the center for more than 20 years, from 1996 to 2017, during which the center really thrived and developed. He's a brilliant researcher. He's the founder of the Danish Epidemiological Society, at least he has said so, but together with others as well, and Marina Skroll, who's sitting over here. And he's also a founder of the Danish Society of Public Health, clinical databases of quality assessment in Denmark, and a lot more. He has received many prestigious research awards, and I could go on, but I won't, because I hope Torben will tell a little bit about it himself. So please, Torben.
Thank you, Adam, and thank you, Kirsten, for this good introduction to. You actually took half of my presentation, but that's okay. Yeah, we are there. Yeah, my name is Torben Jørgensen, and I'm going now in 40 minutes to take you through 60 years of history. It's not possible, so please fasten the seatbelts, because here we go. It was the increased mortality from heart disease that disturbed people. In the USA, the President Roosevelt died from a very high blood pressure just after the Second World War that started the Framingham study. But at the same time, Ansel Keys was more interested in cholesterol and diet, so he did some businessman studies at the same time. But looking at Denmark, you could see this increase in heart disease. It doubled from the 30s to the 60s. And that's, of course, also worried Danish cardiologists and researchers. We will jump 10 years now to the 7-country study, and that was again Ansel Keys, who traveled from US to Europe, and he saw this huge difference between countries and within countries. And he was actually the first in a systematic way to look at the relation between lifestyle, diet, cholesterol, and cardiovascular diseases. He did that in 58 to 64. A Danish doctor from Hansen heard about this, and he went down to have a look at the area. So he went to Dalmatia in 1958. Who was from Hansen? He was a medical doctor. He graduated in 1940. He wrote his thesis in 49, has nothing with cardiovascular disease to do, by the way. And he visited the Dalmatia Dayton collection in 1958. We have a small note from Henry Blackburn. The elderly of you will know Henry Blackburn, I guess. He loved to play his saxophone, and a brilliant epidemiologist. He was a project officer, and we can see in his diary on the 16th of October, he writes, "We had a long electrocardiographic mountain session this evening with much pleasant banter and less pleasant singing, with the From Hansen couple, team visitors from Denmark, working quietly and diligently. He sings bass and staples records with great aptitude." I think it is that Blackburn didn't like the bass singing, but anyhow. We here have the documentation that From Hansen was part of the 7-country studies. He came back to Glostrup, became chief physician at the medical department C, and in 61 he attended a course in epidemiology in London School of Hygiene with Jeffrey Rose, and here he met Gösta Tiplin, who made the 1913 cohort in Sweden. And that was 1 year before From Hansen made his cohort in Glostrup. Now, in the next 5 slides, I'll take you very swift through the history. And then I'll return to some more specific subjects. The beginning was provocative, I think I can say. It was in 64-68 with 2 cohorts, the 1940 and the 1897 cohort. A description of illness and health which crossed the threshold for both the hospital world and general practice. And he called it the biopsychosocial study. I mean, that's what we adapted 5-10 years ago, but he already were there back in the 60s. And then he not only examined healthy people, but he collaborated as a cardiologist with psychiatrists. That's okay today, but in 64? No, I don't think so. He had two purposes: to test hypotheses on heart disease and to describe clinical picture of healthy people. The last one he was very fond of because he could use these data immediately. The other purpose, he had to wait some years for cardiovascular disease to emerge. But it was a hard time because there was no laptop, there was no data manager who could put your data into a computer. There was actually nothing. So it took some time to get all these data available. And actually the plan was to re-examine this cohort every 5 years. But it took 10 years, but then luckily Marianne Schroll came and talked with From Hansen and said, I like to re-examine the 1940 cohort, and it's nice to have Marianne Schroll here in the audience. From Hansen became very, very happy. So he arranged an establishment of a permanent unit he called the Department of Prospective Medicine. And both he and Marianne had this open door policy. If you have a good research protocol, good ideas, you have money to finance your part of it, you're more than welcome to participate. So general practice, health structure of the people, self-perceived health, occupational medicine, sexology, lifestyle intervention, a lot of things came in from the very beginning. And they actually made this table of epidemiological data. But one thing was data, to put it into a machine. Another one was how to handle these data, how to analyze these data. So Marianne, she established the epidemiological research group. So no, Alan, it wasn't me who did this. I'm nearly graduated as a doctor at that time. And that later became the Danish Epidemiological Society, where I also acted. That was actually 30 years ago. So that opened up for fantastic research units in this center. The next time spot I would like to focus on is 1982, where Marianne got us into the Monica study, and I'll come back to that in details a little later. Then From Hansen dies in 83, that wasn't expected. And now more and more researchers came, more and more data were collected, more cohorts were started, and it was, sorry to say, a big mess. Because how to organize this, how to use data in between the researchers. So Marianne succeeded in getting some money in 1990, so we could make a half-time appointment of an epidemiologist. I started the first 3 years, and Jørgensen took over after me, and we simply started to reorganize the whole area, assembling and harmonizing data. Formal contracts were written with the many researchers, simply to get hold of this very, very flourishing area. But I will remind you that all these researchers who took care of the data, they did a very good job. But now we had to harmonize them to be sure that it could be used for the future. At the same time, the political systems think, what are they doing over there? Actually, we didn't exist. As Kirsten said, we didn't have any money or anything. But they asked us, can your data be used for prevention? And there was a young doctor, Troels Thomsen, who said, well, let's try to make a risk score. He worked together with Jørgensen and the chief physician, Hans Ibsen, to develop a Danish risk score. I'll come back to that in details later. So we extended the purpose, and this is very important. From description, of course, we continued with that to identify risk factors for chronic diseases. Yes, we continue that, but then to develop, test, and implement preventive programs. So from the mid-90s, actually prevention had been the main area of the research center. Of course, we need still to have the data to make the prevention. Next hallmark, I will say, was in 1996, where we got a permanent grant from Copenhagen County. Suddenly we had money to apply to employ central figures in the center. We got facilities for for researchers and for the data manager. So Svend Larsen could move from Herlev, where the data was, to Glostrup, so we could interact with each other. And in these many years, the center grew from 10 to 70. So after 32 years as a brickless center, we finally was a physical research center in public health. The county asked us to do some organized prevention and health promotion activity in hospitals. So we contacted Berit Heitmann, who were interested, and later Ingrid Villang took over this area. Then the clinical databases turned up. That was a political decision. I'll come back to that later. Then a new hallmark was 2002. Now we were many researchers. All specialties have been within our cohorts, and the political system thought that this should not be a part of a specific medical department. It should be a independent research center in the Copenhagen County. So, as it was decided, so it became. And we were a research center in Copenhagen County until 2006, and then when the region was formed, we were a research center in the capital region. And there came another job for us, another challenge for us, the regional health profile, which I also will come back to. So the last few years before we moved to Frederiksberg, we were a very well, I think, organized research center with 3 research departments, 1 data department. We had 70 employees, 4 professors and 3 associate professors. Charlotte Lymer decided to have another job, so Ulla Toft took over, and I retired in 17, so Allan took over, and Bettina took Allan's position over at the section for population-based epidemiology. And then you move to Frederiksberg, and it's nice to see that you still have a very good structure, and you even increase the number of employees and professors, so you're really active. It's fantastic to follow this. I enjoy it very much. I'm still a little part of it. So that was a very short history. So what have we been doing? We have, of course, examined cohorts, 15 separate cohorts, all in all 37,000 people. That doesn't sound up so much. When we read the Chinese article, they take 2 million people and examine, But the interesting thing is here that we have many different cohorts. That includes many different specialties. And they often have their separate cohorts. That was due to the open door policy. Many of them have several follows up, and 2 cohorts are extinct. That means that they're all dead. No more endpoints. It's a fantastic paradise for epidemiologists. And we, of course, have been doing much more than cardiovascular diseases. Here are just some of the things we mentioned here in this picture. And some of the presentations today will touch upon these. And we can, of course, touch upon all this in just a few hours. But besides the coming presentation, I will just have a short look at aging, gallstones, headache, child psychiatry, clinical databases, health profiles, and, of course, the cardiovascular diseases. Aging. It's a little difficult for me to just make a short notice on aging, having Marianne Scholz sitting up there, but it was actually part of the initial planning from Hansen, and also Marianne Scholz were very interested, and she became actually the first professor in geriatrics here in Denmark. Is that true? Yeah, good, yes. It was mainly based on the first 2 cohorts. And they want to describe health and functional capacity in the aging process. And for this, they had to develop some instruments. And Kirsten Aulund was very active in developing these instruments of physical activity of daily living and instrumental activity of daily living. Could we operationalize how people were acting? That we could compare both cohorts, so we could see how an old person born in 1897 was compared to an old person born in 1914. I don't think any of them went back to childhood like this one, but there was a big collaboration with our center and 2 centers, one in Jyväskylä and one in Göteborg, in the NORA study, where they looked at aging with similar cohorts. And Marianne finalized the 1914 cohort by an interview of the last survivors when they were 95 years old, which you can see in this book. Fantastic study. To a completely different area, gastroenterology. There was a heavy discussion in the 70s among physicians, epidemiologists, should we remove all gallbladder with stones? Because when we have a gallbladder with stone, it will create symptoms, complication, and even cancer of the gallbladder. We need to ask surgeons to remove all these gallbladders. That was discussed on Herlev Hospital too, especially among Bjørn Andersen on the surgical department and Henrik Wulff in the medical department, and we decided that we would address the Glostrup population study to see could we collaborate on this. So we were allowed in and made ultrasonography of 3 cohorts. We of course looked at prevalence, incidence, and risk factors, but what was the primary aim was the natural history. So Henrik Wulff, Henrik Wulff actually suggested us that we went to the scientific ethical committee and asked not to tell persons if we incidentally found gallstones. That would make them more ill. So we had this discussion and they accepted. So we had a blinded analysis of persons with gallstone. Daniel Münster has just defended his doctoral thesis, and he could in 2016 in gastroenterology show that it was a good idea because only 20% of these gallstones were removed after 25 years, compared to similar Italian studies that had removed all their gallstones after 3 years. And there was no serious side effect. There, of course, was the side effect that they had a high incidence of cardiovascular disease and early mortality, but that's because they had the same risk factors as cardiovascular diseases, and cholecystectomy did not change this. So the conclusion was that there was no need for prophylactic cholecystectomy, and maybe we just should have listened to Langenbuch, a surgeon in Berlin, who in 1882 made the first cholecystectomy. And he said, I jump over the German, okay? In my opinion, cholecystectomy is at the moment suitable only for those cases in which the patient and the physician have reached the end of the patients. I think it's a fantastic comment, and it should be followed today, and many do follow it. Further on to quite another area, neurology. Jes Olesen was chief physician at the neurological department in Glostrup, and he was president of the classification committee in the International Headache Society. They wanted to assess what was the prevalence and incidence of migraine and tension-type headache. It was never really done before in a systematic way, in a classification that everybody agreed on. So of course, Jes Olesen went back to Glostrup and said, well, let us start a couple of cohorts to elucidate this. So the migraine prevalence was stable, they showed, but frequent migraine increased, and tension-type headache also increased during the 11 years the 2 cohorts were examined. And they, of course, found a lot of risk factors, and they made fantastic articles and had a fantastic reference material for further studies in this area. That was just another example. Then Anne-Mette Skovgaard from the Child Psychiatry Department addressed us and said, well, I'd like to make a birth cohort to look at the mental development and development of small children up to the adult age. She collaborated with health nurses who visit all the homes for a newborn baby, and in a standardized way, they registered a lot of things about these small children. And Anne-Mette and his crew, they went on re-examine them, and now they have money for a re-examine next year for 25 years old. They could show that many things influence the development of the mental health of people, and there's a good cohort profile there. You can read more about it. Then we have this Prime Minister, Poul Nyrup Rasmussen. You remember him? The one with a cycle helmet and the bicycle. That was a little too small for him. But he wanted in a New Year's speech, he claimed that it should be possible for the citizen to see the quality of treatment in different clinical departments. Well, how to measure this? Our center was invited to the Doctors' Union to make a report to measure quality by use of a few indicators. That meant you ask the specialists in different disease areas, pick up 8 to 9 indicators where you want to be measured on, and show us you can measure them systematically in the same way. Why? Because we would like to have a fair comparison of clinical departments. If you have a hospital with a lot of social deprived area around and another hospital, just to mention Gentofte, with not so social deprived area, you of course have to adjust for the social inequality. And also we could analyze causes to inappropriate causes of diseases by epidemiological methods. Charlotte Sikera came in charge of this, and she collaborated with, Johan Kjærgaard, who had a clinical unit for quality in Copenhagen municipality. We became a center of competence together with 3 other centers. Unfortunately, maybe, I don't know, but at least it was closed down 7 years ago and centralized in RKP, and the 4 epidemiological departments were skipped in this process. I don't know how it works now, but just an example. Sanne Nordly, she wanted to look at the treatment quality of the type 1 diabetes in children, and she did that by looking at the HbA1c that actually measures the quality of the treatment of the blood glucose. And you could see here that some departments went very well and some did not went so very well. You should then interview the good and the bad departments in her thesis, and she succeeded in interviewing the good departments, but the bad departments didn't have time. But it was a process. It was difficult to keep this data free. I skip this one. But also lifestyle. We are so good at lifestyle when we're epidemiologists. So why don't put lifestyle into patient courses? So we looked at smoking and surgery. Back in the 90s, nobody questioned smoking. I mean, that was okay, even if you were going to have surgery. But we've actually found that there was a 3-fold increased risk of having anastomotic leakage in colorectal surgery. You maybe don't know anything about this, but it's a very serious complication if you were a smoker. This led to a fantastic study by Lars Thu Jørgensen, who wrote 2 doctoral theses in the area, and the health authorities, the national health authorities, asked us to make some recommendations, where we of course wrote that stop smoking before surgery was mandatory, and this is quite common recommendation now. The examples we try to illustrate how we interact with the public system all the time. National health profiles. This doesn't work. Now it works, sorry. It's always good to know how the population how it is. And actually Viggo Kampmann, who was prime minister in Denmark in the 50s, he also thought so. So he started the sickness survey of Denmark in 1951 to 53. I don't know who of you knows it, but it was 87,000 people that were interviewed from door to door over the whole of Denmark. Viggo Kampmann, he loved figures. He would actually have been an excellent epidemiologist. His favorite reading was the annual yearbook of statistics. Then we, of course, made a lot of local health profiles in Glostrup, but the National Institute of Public Health started in 1987, the Health and Morbidity Study, the SUSI study. But then we came to this year, 2007, where all the municipality was told, you have to take care of prevention and health promotion, and if you are in any doubt, you ask the region. A good sentence. There was a politician sitting out in the municipalities what to do. So they, of course, addressed epidemiological centers and said, we like a health profile of our municipality. We did some, and then we decided together with the capital region that we should take care of the regional health profile with the 29 municipalities. The region, central region did the same, and then all the other regions came with us. And now we have this fantastic system of regional national health profiles. It actually received the National Public Health Award in 2012. What does it do? Well, they use questionnaire and register information. Every 4 years, they have a new health profile, and it is timed in such a way that the health profile should be on the table of the newly elected politician in the municipality, so that they can see the condition or the situation in the municipality and what they should do the next 4 years. And it was called well-being, health and illness, but also development over time, so we can see whether the municipality developed in the right direction. And of course, we had to help them because they need epidemiological expertise. So people from our center go out to the municipality and discuss possible prevention and rehabilitation strategies with them. And then, of course, it can be used for fantastic research too. That was a little away from cardiovascular epidemiology, I know, but it's just 2 examples for it. There will come many more examples here today. So let's go back to the cardiovascular epidemiology. And here I will start with a MONICA study, of course, because that's where we were introduced to the international scene. That stands for Monitoring of Trends and Determinants in Cardiovascular Disease. Actually, in the 70s, cardiovascular epidemiologists were a little unsecure whether they had the right risk factors, whether we measured in correct in the same way across countries. So they decided this MONICA study where they made a 10-year project in 38 populations in 21 countries and 4 continents. Just imagine how to organize this. Each had to pick a geographic area, and Marianne, you remember our area was too small in the beginning. And then there we had to make a register for stroke and coronary events and make 3 cross-sectional studies in the beginning, in the middle, and in the end to look at the development of risk factors. The main hypothesis was that if the risk lowered, then the cardiovascular disease also would lower. So that was very exciting to see the first really results here. And here you can see there was a nice correlation between risk and events of coronary heart disease, but it wasn't that convincing. Maybe it could have been nicer. And we also looked at the Danish data with Mette Madsen at the National Institute of Public Health, and we were not that convinced either. And even worse it was for stroke. Here there was no correlation with men, but a nice correlation for women. So, do we do the right things? Do we have the right risk factors? The group continued. We had to look at risk scores, new risk scores. So the MONICA turned into MORGAM, where we took new risk factors in, inclusive genetics. But here in our center, Troels Thomsen and Knut Jørgensen and Hans Ibsen, they started the Copenhagen Risk Score, the pre-GRA program. I don't know whether you can see it here, maybe not, sorry. It's an interactive program. You tap in some unmodifiable data here, age, sex, and so on. And then you looked at the modifiable factors here, smoking, cholesterol, blood pressure, and then you had calculated an absolute risk. But then you could change the risk factors. I'll stop smoke, I'll lower my blood pressure, and you can go down to this risk. That became extremely popular. People wanted all over. So Troels made it in different languages, even in Finnish. But he also found out that it was maybe not such a good idea, because such a risk score developed in one country can over or underestimate risk in other countries. And he made an article here where he showed that the Framingham risk score overestimated our population, and our risk score underestimated Framingham and the Finnish population. So this called, of course, for calibration. And that came into the heart score program, which now is adapted to the various European countries to be sure that they get the right calculation. And if you want, after this presentation to have a look at your own risk. Just go to the homepage of the heart score and tap in your data. You need a cholesterol and a blood pressure and the weight, and you can see your absolute risk for the next 10 years. But epidemiologists are never satisfied. They went on with a biomarker study because we needed to be even better with these prediction models. And there we had all the biobanks. So they analyzed biomarkers and put into the prediction model, could we be better? And they actually dreamed of personalized prevention. We still participate in the biomarker. I just saw the latest manuscript from them where they put in 4 or 5 new biomarkers. It's just been accepted for JAMA, and we don't move maybe on the 3rd decimal or something like that. So I think it's a pipe dream. But at the same time, we were told by a Cochrane review that this individualized prevention, we should stop it because it doesn't work. But it was, of course, old studies, no use of risk scores. So we thought in 1999 could do it. So we wanted to see whether a screening, risk assessment, and health counseling over a 5-year period could lower the CVD burden in society. We had the pre-CAR program with absolute risk measurement, tailored prevention program, all these things. So we invited 13,000 for screening, high-risk person, came for counseling, both individual and groups, 4 times in 5 years, and 50,000 in the control group. And then we followed them in registers for over 10 years. And for the results, the intervention group is the red one. As you can see, they got a little more ischemic heart disease than the control group, but luckily it was not significant, so we could conclude there was no effect of this type of screening. But at the same time, the Helle Thorning government had promised the population during the election campaign that that would make a general health check of the Danish population every 4 years. So I went up to Astrid Krag and showed her these data and said, well, it might be a bad idea to do this. And she was actually convinced. We had a long talk. And she said, okay, I think you have convinced me. So now it's one of our broken promises, evidence-based, she said. Then WHO asked us to do a systematic review to see whether it was just Inter 99 who didn't make it. But as you can see here, there's no effect whatsoever on high-quality studies looking at lowering CVD burden in society by screening. It doesn't help. So why? It's because we, of course, have been looking at the individual. We need to look at the surroundings, the environment. If that does not encourage or directly discourage such changes, it will not happen. And here we were extremely lucky to have the Helsefonden because they provided us with a nice grant which made it possible for us to go through all this system from individualized to population level interventions. We made a review of literature showing that the population health approach is effective, it's acceptable, it's cheap, but it needs political decisions like legislation, bans, availability. But we need to realize that if the structure of society is not in place, forget everything about the individual advice. It will not help. But here we suddenly saw that there were some vested interests that seemed to be the major problem. You remember, Charlotte, your long journey with the tobacco company, where Charlotte have shown how the tobacco company acts, cast doubt on strong scientific evidence, and the public will not know what to believe. And we went on with the big food and the big booze, and so they used exactly the same way of tackling this. Then we looked at the Danish fat tax. You remember the fat tax a few years ago? Industry used this simple mechanism to get rid of the fat tax. And then suddenly Ansel Keys came up again. You remember him from the 7-country studies? Because he was the guy who punished us with low-fat, non-cholesterol. You remember these sentences. Because he said that was dangerous. Sugar, refined sugar, doesn't matter. Well, Jørgensen said refined sugar was the main killer. But they fought Jørgensen and Ansel Keys, and Ansel Keys won, mainly because he was heavily sponsored by the sugar industry. But we went on. Could we go into a society to see whether we could change the structure of society to have a healthier population? And that's Charlotte Glymer and Ulla Toft who made this Project Sol. That was on a municipality Bornholm, where they, in 3 cities, talked with the supermarkets to reorganize their goods so people were nudged to buy more healthy food. They went to the schools and kindergarten and also the television Bornholm. And they compared it with development in Odsherred and could see that you actually could influence the behavior of the population. And of course, this went on to our healthy community, where they now work with 4 municipalities to develop and test sustainable models for health promotion and prevention. And they, of course, use complex interventions. This changed in our center from the mid-90s, where the politicians became aware that we could deal with prevention. It was actually a natural consequence that they had chosen to put the intersexual prevention laboratory in our center. Here we facilitate that partners and organizations from different sectors can meet and develop intersectoral partnership projects on prevention and health promotion. 5 minutes? Great. Now we have to lift our head. Now we've been looking at the computer and calculated many risk ratios. What's happening in Denmark in the same period? Well, very funny. We have become a low-risk country. Here back in 1970, we were a high-risk country. And then we've just lowered down here to 2018, and we have a risk even lower than Italy. And remember, Ansel Keys was very fascinated by Italy and the low mortality rate. Why? Well, we contacted Simon Cable, our good colleague in Liverpool, who have made an impact program where he could look at the decline in mortality and combine that with the improvement in treatment and change in risk factors. And that's what we did in this big study, and could see that reduction was due to risk factor reduction in 40% and improved treatment in 25%. But still, we haven't explained everything. So Kirsten Bjørnsbo went on with a trans fatty acid, which is a very dangerous fat. It's forbidden now since 2004. Denmark was the first land to forbid it. But we can see here that it was faded out a long time before. So Kirsten used again the impact model to see what it meant, and actually explained 11% of the CHD reduction in mortality. Even more important, I think, it showed that this kind of intervention reduces social inequality. So if you want to reduce social inequality, go for the structure in society, not on the individual level. For the conclusion, well, what have I tried to tell you? I tried to tell you that Glostrup population study, they performed the first clinical examination of a random sample of an adult population. And thank you to very visionary persons like Tom Hansen and Marianne Schroll. It was from the very beginning that they were inclusive according to other specialty. Come with your protocol, come with your study. We'll discuss whether we will perform it together with you. So we developed from a section for data collection to a physical research center in public health. And we still describe health, you can hear today. We still identify causes to diseases, of course. But we have really worked hard in developing prevention from the poor individualized to the more complex intervention. And that is to have an evidence-based solution for a healthier population. Public health, that's policy. So without politicians, you cannot do this. So of course, we've been interacting with the political administrative system. And then, of course, we had a vast international and national collaboration. And the final slide. Oh yeah, all of this has been possible only due to fantastic researchers, hundreds of researchers who've been using our data. We are so happy that people do it. But last but not least, a fantastic personnel who year after year have been, let me use Henry Blackburn's word about from Hansen in 58, working quietly and diligently with great aptitude to collect and secure data for researchers. Thank you very much.